I do not have any ongoing care from a cardiologist following my sudden cardiac arrest. There is just the normal monitoring of my ICD by a technician. Given I am on a host of drugs, including beta blockers, how should my drug regime be reviewed and controlled? I have a GP and a nephrologist, but to my mind they may consider my blood pressure in isolation and may not be totally au fait with the cardiac implications.
Yeah, I mean, so my personal view would be that I think you would benefit from being to see a cardiologist. I think that we know a lot of the time some drugs are very helpful in the early stages after an event. Maybe if we don't know what the etiology is, or we don't know how the pump is going to improve or not. And so I think that, you know, when you get discharged home following a cardiac arrest, I think you know, we don't have the full picture. We have the major components, but we have to rely on then follow up to see how the patient goes. Do they have any more arrhythmia? Do they have any more cardiovascular symptoms? And we know also that, you know, the drugs we give you, including beta blockers, do have a number of side effects which not everybody gets on with. And so my personal view of what you say is that I think this just shows how poor we are as a group of individuals, cardiologists, at following patients like you up properly. And I think that there's a number of reasons for this, which we've talked about in the last webinar, but some of that is that a lot of this stuff is done in a tertiary centre, and then patients are then discharged back to a district general hospital for their longer term follow-up. And you only need that letter to go walkabouts and not make it from A to B, and unfortunately then you've got no follow-up. So I think that patients like you will benefit from seeing a cardiologist, even if it's just that you can have the peace of mind that you're on all the right drugs for good reasons, that you're happy that you're not having any major side effects, and that you're very happy therefore that your ongoing care is spot on. And I think you just ask your GP to refer to a cardiologist, maybe back to the one that you first saw if you had faith in those, because it's always nice to have continuity. But I think it would be absolutely reasonable to have an outpatient appointment to go through things in the cold light of day now and see if there's any changes long term that would be beneficial.
I think we do a very British thing of seeing our GP and not speaking out at the right time. I encourage all of our patients to see their GP and to speak out and to say, well, if you don't know, why don't you refer me on to someone that does know? And our job in the clinic is to follow up the device and make sure the device is working. So if there's any issues with the device, we'll obviously sort them out. For the finer details, though, sometimes of looking after some medications, your GP should be aware of your medication regime, and they know the other things that are going on with you. I'm not always going to know that you're seeing a nephrologist for some other condition. So it does always, I think in my mind, come better coordinated from the GP, but I think as patients you have to stand up for your rights and to say when you're not happy to your GP, hey, refer me back to my cardiologist because I haven't seen him in 7 years and, you know, I'm getting these issues and the physiologist said that I needed to see the cardiologist again.
Mm-hmm. Okay, sounded nice. Okay, conscious that we've been going for quite a while now. So we probably
we lost it, haven't we?
We're try and crack on through the last bunch, but if some of the longer questions we may not be able to.
Why don't we be short and
quick fire round?
Well, yeah, that's a good idea.
Quick fire round.
Okay, we'll go 10 minutes just to sort of
Right. Okay, I did have a question which I know some other people wanted to ask, which I haven't written down yet, and it was to do with the settings on your device. When someone comes and sees you, what are those settings that could be changed?
Lots of different settings, lots of changes that we can make and we do make. However, they're patient-centred and they're evidence-based. It will be different for every single person, really. But we set the device up so that it works for the individual. It depends if you're secondary or primary prevention, so if you've survived a cardiac arrest and we've seen the arrhythmia, we set the rate up below that. If you're just a primary prevention because you haven't had a cardiac arrest but you're likely to, we set that at a standard rate. But they will vary between each individual. We give the personalised touch.
Okay, alright, some quick ones then. What do you think of the drug Amiodarone?
Amiodarone, yes. So amiodarone is probably the most powerful drug at preventing certain heart arrhythmias. And so I would say to you it's a good drug when used in the right patient. and we see patients' lives completely improved by preventing their arrhythmia using this drug. Is it a drug to give to everybody for a decade? Absolutely not, because it does have side effects, liver side effects, thyroid side effects, and sun exposure side effects, which some people don't like. But is it a good drug in judiciously used selected patients? 100%.
Definitely.
I think that's all we can do. I think that there's good, reasonable evidence for it, and it works, and you have to be mindful of any side effects you do have and bring them up with your clinician and work out the pros and cons of what this drug's going to do for you.
I think it's a balanced decision amongst the experts and the patient. If you're saying that you live in Spain, for example,
That's right.
and they want you to go on amiodarone, you've either got to make that decision that you're not going to go to Spain, or that you're not going to take amiodarone and potentially you're going to get some shocks from your device.
Absolutely.
I mean, someone's just commented on that drug. What are the long-term prospects of being on it? Is it a short-term remedy, or is
it depends upon the indication, just like anything in medicine. It's all about the indication. I think if it does a brilliant job, I tend to use it for my patients, usually in a relatively short term for less malignant arrhythmias, actually, for less harmful arrhythmias like atrial fibrillation, and I give it for short periods of time, and it's brilliant. And then we tend to use it only in those patients with malignant arrhythmia where we can't use other drugs, or other drugs aren't working well, or the device can't help us anymore. And so it's not a first line. It's sort of second, third, or even fourth line, depending on the patient. So we try and avoid it if we can, because it does have liver, lung, and thyroid abnormality effects longer term. But at the same time, it's a great drug.
Definitely, yeah, I agree.
Okay. I'm always very tired, even after having lots of hours of sleep. I've been told it's the beta blockers. Is that right? And to follow on from that, from a comment and also my personal experience, now weight gain, is that related to beta blockers?
Because you eat too much.
Probably.
Are they still awake this episode to hear the answer?
So no, I think there's two components to this. I think that if we're talking about patients who have had a cardiac arrest, which presumably we are,
yeah.
I think the first thing to say is that patients who have cardiac arrest are exhausted for a number of months or years afterwards, and I think that is not well defined, not well explained, not well understood. Mechanism is not well understood, but I think it's brain injury. I think brain injury makes you exhausted, and I think that if you have a cardiac arrest, it's the ultimate insult to the body, and I think it takes months to years to physically recover from in some patients. When you then add on top of that a number of drugs that can then make you tired as well, it's, in my view, no great surprise that people feel exhausted after this on decent doses of beta blocker, or maybe on some blood pressure pills that they've never been on before that lowers their blood pressure. So I think, for me, it's absolutely expected, and I think it's a combination of an incredibly severe illness, but not only that, drugs that would, in people who are healthy and fit and not have cardiac arrest, would also feel more tired. So add it all together, and I think that's what you get, I'm afraid. But I think do not underestimate the tiredness effect of cardiac arrest.
What do you think of coenzyme Q10 Ubiquinol? The research looks great.
Yeah, I mean,
Never heard of it.
this was out some years ago, actually, as a sort of. I don't think the idea behind it is it's necessarily good for all cardiac arrest, but I think it's potentially, and I don't know that there's any good randomised controlled trial, which is actually what we need to prove benefit of anything, to prevent coronary disease. I think it potentially prevents coronary disease by having an antioxidant effect. But the trouble is, because it's cheap and over the counter and not worth anything, so you can buy them for about £8 or something, then there's no commercial gain by doing a 10,000 patient randomised trial, so it will never happen. And so I think that if you want to buy it and take it, great. If you don't. But I don't think it's a game changer.
Okay. Is it common to keep getting chest infections following my heart attack and then subsequent cardiac arrest?
So I don't think it's uncommon. I think probably the driver is, I think, again, we don't know, we don't have the information, but after a cardiac arrest, often the heart muscle is weaker. And when the heart muscle is weaker, you often get fluid in your lungs. And if you get fluid in your lungs, it's like a soggy sponge. And I'm afraid you are then, by definition, more prone to infection. So the answer for me is yes, and the mechanism is because the heart may be weaker. If the heart's not weaker, then for me it's a little more difficult to explain. But if the heart is weaker, then it will generally be that's the mechanism.
I think a key point there is just to keep an eye on the wound as well, though. I think if you've got signs of infection and they're not going away with repeat antibiotics and your GP thinks it's a chest infection, keep an eye on your wound.
Yeah.
Okay. I was told I have the new type stents and will be stent free in 2 years. What does this mean? It terrifies me to think I won't have stents and I'll get blocked arteries again.
Yes, okay. So the new stents are called Absorb, and they're no longer put in, interestingly, or not at the moment. So they do disappear, but there is good evidence that they disappear, leaving, if you like, no trace, and that the artery then remodels afterwards very nicely. At the moment, they are a little bulky, and actually in the first 5 years, potentially are associated with a slightly increased risk of blood clots forming within it. So I think that the risk potentially is a very small risk of a blood clot forming within your artery, but while your stent was put in 2 years ago, I hope, then you should be free from that risk. But the fact that the stent has disappeared, most people perceive as being a good thing, because you haven't got metalwork staying there for the rest of your life that potentially can cause clot on it. So the idea is a good one, to put it in, open the artery, salt the artery, and disappear as if it was never there. It's a perfect scientific solution, but the technology as of yet is not quite perfect.
Okay. Just going back to the beta blocker one, is there an alternative that people can take that won't cause weight gain or increase in blood sugar?
We'll see what beta blockade action is. In heart failure, there is a drug called Evabradine, which is very good at slowing the heart rate down, which is often what we're trying to do with a beta blocker. We're trying to slow the heart muscle down, make it work less hard, and actually improve the ejection fraction a bit. But Evabradine doesn't have the same beneficial effects on arrhythmias that beta blocker does. So unfortunately, beta blocker is a really good drug, but it does have associated with it a number of effects that can be suboptimal for patients' life,
Okay.
which is a problem.
I had a heart attack which triggered a number of cardiac arrests. I don't have an ICD. Is there any research or statistics which suggest that a further heart attack would also be likely and result in a cardiac arrest, or is there any increased risk of a heart attack survivor later having a non-heart attack related cardiac arrest?
Yeah, I kind of get what you're trying to say, but I think it's quite difficult to answer that question. I think if you've had a heart attack which has given you 4 cardiac arrests and you've had an ICD, the suggestion from...
No, she doesn't have an ICD.
I don't know, fine.
I think she's worried that it's going to happen again.
Yeah, no. So I think the key thing here will be that you've got a good pump, so the pump's not been badly damaged, otherwise you potentially would need an ICD, which you clearly don't. That's the important thing, number one. Important thing number two is we've got to prevent a heart attack, and if we can do that effectively with a combination of statins and other medicines to prevent you having it, then the chances of a cardiac arrest are very, very low. And so I think that the chances of a further heart attack and having a further cardiac arrest, I would say, are incredibly low. We can never say 0, but incredibly low.
On that, there was some research done that looked at patients that had a cardiac arrest as a result of their heart attack and were given defibrillators. They did statistically worse than patients that didn't have a defibrillator in the same category. So you're in the better category.
Yeah, absolutely. And when you've got an absolute hard cause causing it, if we can prevent that cause happening again, then that puts you in relatively good shape. So I think that, I think you'd be incredibly unlucky.
Okay, you've virtually answered this question before I've even asked it. That's a bit like the 2 Ronnies, wasn't it? This person doesn't have an ICD and they had a heart attack, which was the cause of their cardiac arrest, and they're always asked why they don't have an ICD.
Yeah.
I think you pretty much.
Yeah, so it'll be for 2 very clear reasons. Number one, that there was a very clear reason why you had your cardiac arrest. Your artery was blocked. If my artery is blocked, his artery is blocked, we are likely to go into cardiac arrest. That's what happens when a muscle hasn't got enough blood supply. Number 2, by definition, your heart muscle must have recovered. So your heart muscle won't have huge amounts of scar and the function will be good. And we know that patients who have got an artery that gets opened and that have a muscle that is not badly damaged do really, really well. And so, as James just said, there is absolutely no benefit from you having an ICD. In fact, all you'll do is have all the risks, which are infection, bruising, living with an ICD and all the other things without any perceived benefit. So complete waste of time. But the key thing is prevention of a further heart attack. That is absolutely vital.
Okay, and this is sort of follows on from those about who gets an ICD. In the UK, we implant ICDs significantly less when compared to Germany, and this person supplied a chart of data. Compared to Germany, France, Italy, and a number of other European countries, is the UK's criteria for implanting ICDs as defined by NICE in need of review?
It's interesting because I've seen that data and it's very true. However, recently, my experience, and maybe Tom's, is that we are massively ramped up the amount of devices that we are implanting.
Do you know how many are implanted in the UK each year, and how many of those are for precautionary reasons?
For example, I don't know that specific data, but I know, for example, that in our centre we've gone from implanting 5, 6, 10 a month up to 30 a month. So it's a dramatic increase.
In what time frame is that?
Over the last couple of years. A significant amount. So much so that the demands of seeing your patients for the post-implant checks and the routine follow-ups is quite difficult. We get you done, obviously, but there's a lot of pressure now because of the amount we are implanting. Yes, we're still behind places like Germany where they seem to put them in if you fall over.
Mm-hmm.
But I think, as we've mentioned in the previous questions, we're doing it for the right reasons. I know that NICE guidelines sometimes seem a bit backward or behind the times, but in my experience they're pretty reasonable, and we don't want to implant devices in the wrong people because it can be catastrophic, and you deal with the consequences of infections and bruising and inappropriate shocks, and patients, the simple things like not being able to go on holiday because they can't afford the insurance to go away on holiday. So
I think we mustn't presume that more is actually correct.
Yeah.
So I would suggest to you we are probably still under implanting generally, but I would suggest to you that Germany is over implanting.
Yeah.
So the correlate that you're looking towards is wrong, if that makes sense. Because they get paid for every device they put in. So if I'm a device person, why wouldn't I put a device in? So it's the wrong. Whereas in the UK, we all get paid the same, regardless if we put one device in, 10 devices in. As long as we've got to put them in the right patient. So I would argue to you that I think we are a little bit under because of resource and because of setup, etc. But I would suggest that they're over implanted.
Interesting though, we are nearer the top now of CRT defibrillators and CRT pacemakers.
Mm-hmm.
Our focus is more shifting on the heart failure side of things, and there's been some studies over the last few years that have probably changed our perspective and our practices so that we do implant more CRT defibrillators and bog standard ICDs, to be fair.
Mm-hmm. Okay, this is a little bit of a long question.